we use this 3D workstation like Ed has shown for all our patients to do our sizing. And I will show you now the use of the avatar medical device, those 3D glasses, as the next step to decide in a better way what we will do for our patient to choose between endo or open repair. This is an example of a patient with asymptomatic right renal aneurysm. This patient has a small right renal, as you can see on this 3D workstation, and we used to do a CPR to choose the most accurate stents that we will use to treat this patient. And if there is too many branches, we usually choose to do an open approach for those kind of aneurysm to keep the most important part of the kidney with a good patency. This is a decision, and we use a standard workstation. As you can see, you have a 3D view, but it's on your computer, and you have only a 2D view. It's not really a 3D view. And when you use those 3D glasses, you have really the impression to be inside your patient, like in an open approach. You have the vision of all the different branches. So it's very difficult to explain you what is really the advantage not using the glasses. But indeed, this is the image that we can have with the avatar, but you need to imagine that it's a 3D view, and you can see all the afferent and efferent branch, and what kind of branch you can keep. I think it's the same approach for cerebral aneurysm. For cerebral aneurysm, you need to keep all the branches patent, and it's more challenging, but in this case, in a patient with a bad renal function, we need to keep all the branches patent. So you have this view, like Elodie has shown. You have a 2D projection on the anterior and lateral part of your screen, and you can see the small aneurysm. So for this patient, we decide to do an endovascular exclusion with a pre-embolization. We need to embolize only 2 branches and keep most of the parenchyma patent. You can see the branch embolization on the upper part of the kidney with microparticle and microcoil, and secondary, we exclude the aneurysm with a small covered Bentley big graft stent. But the control angiography has shown a distal endoleak, so there was a failure to treat and to exclude the aneurysm. So we start to do a flaring of the distal part of the covered stent, but finally it was necessary to do a microcoil embolization of this small aneurysm. This is the final control of this exclusion of this aneurysm, and I think it's quite a good result because I'm not sure with an open approach we would have a better results in terms of preservation of the kidney. So recently we have done a pilot study to analyze for visceral artery aneurysm the use of these 3D glasses, this virtual reality program, in order to optimize treatment selection between endo and open repair. The analysis was performed by surgeons involved in 10 patient cases. So we prospectively look at the CT scan first with the 3D workstation, and then with the VR headset running the Avatar medical software. The aneurysm were managed by open repair or endovascular embolization or stenting, and 3 vascular surgeons analyzed the CT scan before the different therapeutic options. One with the standard 3D multiplanar reconstruction, and then with the program. Visceral aneurysm analysis and procedure planning, the surgeon answered a qualitative variable-based questionnaire using a discontinuous scale of approval level. So we enrolled 10 patients, 4 splenic arteries, 2 renal, 1 celiac, 1 both splenic and renal, and 2 duodenopancreatic arch aneurysm. And all surgeons experienced the location of the aneurysm, the number and the position of all collateral branches, also the diagnostic accuracy using this virtual reality. We show a better procedure planning and anticipating challenge that was reported, and I'm going to show you the result of this study. So in 90% of cases, the surgeon understand better the anatomy and analyze better the position and the 3D vision of the aneurysm. They also better analyze the afferent and efferent branches, and that is the most, I think, challenging part of the visualization of visceral aneurysm. And what was the impact on the surgical decision? They have a better confidence in the choice for endovascular versus open surgery in 90% of cases. Also, they can better plan only in 70% of cases the therapeutic option. They also go faster. They go faster to make a surgical decision, and they go faster to gain some time in surgery in 50% of cases. So in conclusion, this pilot study shows consistent results regarding the use of virtual reality for preoperative evaluation of patients only with visceral aneurysm. The learning curve using this device is short, and the analysis process is not time-consuming. And I think you have to use for all your patients a 3D workstation, but I think this new tool that is not actually on the US and the European market is a promising tool to optimize your treatment selection. Indeed, you have a real 3D view of the inside of your patient, and you can better decide how you will perform your endovascular treatment or your open repair of this small aneurysm.